This webinar will also be posted up on our YouTube space. So any of you want to go back and see what we've discussed, it'll always be available on our YouTube space. And a small note is there'll be a small survey coming up after the webinar. It would be great if you could fill that out for us. It'll help us to better inform our future webinars and help us plan for more such topics. A quick update about what Network is. Network stands for the New England Children's Behavioral Health Network. We started in 2022 with partnership of Bradley Hospital based out of Rhode Island and Connecticut's Children. Our main focus is to improve children's behavioral health access, not just for children, but also for families, promote preventive, equitable, accessible, and family centered continuum of care approaches. And we want to serve as a connective tissue. Just an example is right here. Bring in leaders from across the New England region, learn from them, and share their perspectives. We want to foster more collaborations and such networking with different topics. So if you have any ideas, please feel free to shoot them across to us. And we like to keep highlighting best practices when it comes to children's behavioral health. And joining us today, we have an exciting panel over here. We have Lisa Say who is a senior advisor at the National Council of Mental Wellbeing. We have Sybil Mazrul McRae joining us from Maine. We have Susan Stevenson joining us from Rhode Island, who is the director of the CCBHCs and Children's Services Gateway Healthcare. We have Lee Robinson from Massachusetts, who is the Associate Chief of Behavioral Health at Massachusetts Executive Office of Accountable Care and Behavioral Health. And we also have Margaret Eichner, who is the Deputy Director of Behavioral Health Policy from Mass Health. Thank you so much for joining us. We are truly excited to kickstart this webinar. And I will now pass it over to Lisa, who's thoughtfully helped us to moderate this webinar. So over to you, Lisa. Thank you so much.
Thanks, Ash, and welcome everyone. We have 1 hour, which is not nearly enough time to cover all of the rich topics that we've got teed up for today, so I'm going to jump right in. Here's the game plan, knowing that time is of the essence. First, acknowledging that we've got a really great diverse group with us today, representing a number of many different organizations and varying levels of knowledge about the CCBHC model. We're going to kick off with a really quick overview of what the model is to set a strong foundation for the conversation that is to come. Note, you'll see a lot of content on the slides, which I will not go through in fine detail. Mostly I've included the information there so that you will have it for your reference and can come back to it as needed. We will then have the opportunity to hear directly from our amazing colleagues in Maine, Rhode Island, and Massachusetts, who have implemented and are actively managing CCBHC programs in their respective states. We are very fortunate to hear from both the clinic and stateside today for a mix of perspectives. And I'll just quickly note that Massachusetts has implemented a unique flavor of this model, which you'll get to hear more about. Each state representative will have about 5 minutes to provide you with a quick overview of their implementation experience and current CCBHC landscape. We'll then segue into a really meaty round-robin discussion where you get to hear from each panelist about topics that we imagine many of you are presently mulling over in your respective states and organizations. Such as implementation best practices, pain points, strategies for overcoming common challenges like funding and sustainability, and ways that you can tap into the CCBHC model to further improve the behavioral health continuum of care in your state. So last but not least, some general housekeeping rules before we formally jump in. 1, we ask that you hold your questions to the end. We will have, as you can see, time fully allocated for open floor Q&A. And 2, one of the hats that I'm wearing today is that of time cop. So I might interject at points to ensure we stay on track. We're not cutting the conversation short. There are things that we could perhaps put in the parking lot to come back to, or could save for a future conversation. I will help guide us along. So with that said, let's go ahead and get started. Ash, if you could go to the next slide. Great, thank you. Okay, so first and foremost, what is a CCBHC? It is a mouthful. It formally stands for Certified Community Behavioral Health Clinic. So oftentimes you will hear this acronym and term used in two different ways. One, it in itself is a federally defined model for integrated behavioral health care delivery. And two, it is also a certified or a nonprofit clinic that is able to meet a high set of standards that are established at both the federal and state levels. So the fundamental scope of practice here of services that every single CCBHC is expected to provide are at minimum these 9 core services that you see on this screen. And I'll just note of importance, this is a home and community-based model of care, and CCBHCs are all required to provide clinically appropriate supports for individuals of different ages across the lifespan, and also varying levels of need, including those with SMI and SPMI, severe SUD, and children and adolescents with SED. Next slide, please. All right. So what is it that makes a CCBHC unique? How is it different from the CMHC model that many states operate or used to operate? And how is it transforming how we fundamentally deliver behavioral health care across communities, states, and the nation? On this slide, you will see some of those distinguishing factors that is unique to the CCBHC model. Something to call out is very different from the CMHC models. You actually have to provide 24/7 mobile crisis services. And it is also enhancing time to service. So for routine need, clinics are required to provide services within 10 days of initial request from the client. And as mentioned, this is also really about an integrated, comprehensive, well-coordinated approach to care. So we're considering not only mental health needs in a silo, but also thinking about treatment for those with an SUD comorbidity, or other supports that expand outside the traditional medical clinical model, like social determinants of health factors. And this model, as one last highlight, is that it also focuses on delivering services outside the traditional 4 walls of a clinic. So that really means meeting the client where they are, in the community, in the homes, and through innovative partnerships that clinics might be establishing with their local police department, their schools, their primary health care providers, etc. So a little bit about the certification criteria. When we say we set a high bar, what does that mean? What this means is that the model in itself is nationally defined, but state-driven and locally achieved. At the highest level, there is a core set of established standards from CMS and SAMHSA. Beyond this, states are purposely provided with a good amount of discretion to layer in extra certification criteria based on the local landscape of resources and needs. So for example, this could mean states can use discretion to layer in minimum service thresholds, require staffing models, and also required evidence-based practices. Clinics lead in and lead the way by demonstrating the value of specific types of services. They are the boots on the ground. They have worked in these communities for decades, and they can bring a really strong perspective and work with state agencies to shape what the CCBHC program ultimately looks like within their state. This, in a large way, is a pathway to scale and sustain innovative approaches to care that might have previously been incubated at the clinic level, leveraging, for example, grant funding from different sources. And the last thing I'll say here is that each of the core services of those 9 must be directly delivered by a CCBHC clinic or through a partner provider that is known as a designated collaborating organization, or DCO. You'll hear this term likely come up again in the rest of this hour. And what this means is it presents a unique opportunity for everyone to be maximizing existing resources within a community and to develop a network of truly integrated care. Now we're going to move into the nuts and bolts about funding, because I know that is of course, an important part of this conversation. So what this slide lays out is there are a couple of different implementation pathways. What you will see to the right is a more clinic-driven approach. So clinics have the ability to apply for direct funding from SAMHSA for these kind of incubation grants that help them develop, plan, implement. The other kind of more solidified pathway is through state Medicaid. And through state Medicaid, there are a couple of different flavors even within that. Most states, but not all, start through a demonstration program. The federal demonstration program selects states in through a competitive process. SAMHSA just announced the most recent cohort of 10 states who got in, so congrats to them. And this is special because it provides an enhanced federal match rate for 4 years to states. It's an opportunity for the states and the clinics to trial and innovate before locking down what their program looks like via a more formal Medicaid state plan amendment, or SPA, as it's commonly known, or a waiver. And so this is just different pathways that folks can take to bring this program live and to sustain it over time. Next slide, please. And when it comes to payment through the Medicaid system, this is done through what's called a prospective payment system, or sometimes you'll hear a PPS rate. There are different flavors of this. There are ways to do this via a daily rate that a clinic might be able to collect, a monthly rate, and then the newest options on the table are 3 and 4, which basically allow states to consider a carve-out or a special rate specifically for crisis services, knowing that the delivery intensity and scope of that specific service line tends to be unique. So I won't go too far here, but essentially this is a cost-based model of reimbursement. And there's a complex way to set the rate through what's called cost reporting, through set templates by CMS, but this is a vital part of how this program is funded through state Medicaid. Now, next slide, please. Where are these models found? Where are these clinics found? It's been nearly a decade, not quite, but getting close to when this conception came to mind through the, kickoff of the demonstration program. And right now, across the nation, there are only 2 states where there is not yet a formal CCBHC, and that is South Dakota and South Carolina. Just some high-level highlights as of April of this year, so just a month and a half ago, 40% of US counties are served by at least one CCBHC. 63% of the US population live in a county with a designated CCBHC. And 9 states have made this program permanent through Medicaid, and 24 states have initiatives underway, either with the PPS or a different flavor, such as Massachusetts. And next slide, please, let's actually get to the heart of what we're here to talk about, which is what opportunity does this present for children's behavioral health specifically. What you'll see here is a slide that is based on a survey of all state certified CCBHCs and grant recipients that was conducted in 2024. And we actually got responses from 380 unique clinics nationwide. And this is what they shared, is that CCBHCs are helping to improve access to care and quality of services for all populations, but most significantly for children, youth, and families. This has been the greatest growth in their clients served are those ages 0 to 17 years. So next slide, please. How are CCBHCs directly supporting children, youth, and families? Well, CCBHCs, as mentioned before, provide behavioral health supports across the lifespan. And not only that, but the services they provide have to be tailored and age appropriate. 2, client voice and input from those with lived experience matters. This input has to be taken by the state and clinics to inform program and service design. And three, this model really considers the family or household as a unit and ensures support for not only a child, but really the caregivers who really surround them in this space. And next slide, please, is just to kind of seed, opportunities for maximizing impact. There's a lot that we're going to explore today with our panelists, and that's ways that clinics are offering actually intangible ways intergenerational care, how they're helping to bridge services and supports for transitioning youth, and also how they've really leveraged this model in concert with other resources on the ground to really have true wraparound and coordinated supports for children and their households. So that's enough for me at this point. I am going to hand it to Sybil from Maine to share more about this program in her state.
Great. Thank you so much, Lisa. Hi, everyone. I'm Sybil Mazerol-McCrae. I work at the Office of Maine Care Services. That's our Medicaid office within the state of Maine. And I am the CCBHC project lead and have been working on developing this model since summer of 2022. Next slide. Great. So Maine was awarded a SAMHSA CCBHC planning grant in 2023. That is the pathway forward to allowing you to develop your CCBHC model for a year in order to be eligible to apply to the federal Section 223 Medicaid demonstration. We in Maine currently have 5 provider organizations that are participating in our demonstration as CCBHC locations. They are covering 10 counties within our state. We have 16, but we have coverage of the CCBHC model across 10 of our counties. Our demonstration clinics overall are serving nearly 14,000 individuals, at least on the Maine Care member side. It's larger than that on the commercial payer and uninsured side. But approximately 4,000 of those individuals are youth, children and youth. We did choose to incorporate our behavioral health home and opioid health home services within our CCBHC model, and that is an innovation or an approach that Maine took that not every single demonstration state chose to pursue. I'll say across the board for all of our CCBHCs, each provider must select a youth-focused substance use evidence-based practice. And we had selected either the ACRA EBP or multi-dimensional family therapy as one of the evidence-based practices that the providers can choose. Some providers have actually had clinicians trained in both modalities. This is in allowing our state to increase capacity to better support youth with SUD, and that really aligns with our Maine's overall opioid strategic plan. You can go to the next slide. So like I said, we have 5 CCBHC organizations covering multiple service areas primarily. We have the opportunity within our state to define what a CCBHC service area is. And so Maine selected the county level. Some opportunities that participation in the demonstration allowed was our state discretion in designing certain evidence-based practices that were either allowable or required for both youth and then adult. As an example, within Maine, Medicaid hadn't previously been reimbursing for EMDR. And this is a really great modality for folks that have trauma. We have our most rural CCBHC organization that has been able to train 10 clinicians in EMDR for both youth and adults that experience trauma. And they have, in the last year, since joining our demonstration, increased staff hiring by 15%, which is really exciting, especially in a rural area. Our Aroostook County is our largest county, and least densely populated county. And so they put a lot of effort into hiring on clinicians to provide these types of services that Lisa had described. Within our kind of central north area, we have community health and counseling services. They were one of our first early adopters as well. They have implemented and sustained through their CCBHC model a youth-focused behavioral health urgent care site. This is offering 8 hours of urgent care support for youth and families 7 days a week. So folks can walk in, and it helps with diversion away from the emergency department. They have also developed and are sustaining through their CCBHC reimbursement a rapid aftercare support service. So this is really pairing a clinician with a BHP to provide in-home support both for families and youth that have experienced a crisis and or have had a recent foster care placement to allow for some support to the whole family unit. Within our central Maine area, we have Kennebec Behavioral Health. Through their CCBHC, they established a multi-systemic therapy team, which we hadn't seen in this area. And they are the first CCBHC to be approved by the state to offer high fidelity wraparound case management. And our most populated county, we have Spurwink. They partnered with our Department of Corrections prior to implementing CCBHC to offer family functional therapy to youth with justice involvement and have been able to sustain that through their CCBHC model. And they are also providing trauma systems therapy for immigrant and refugees to better support our new Mainer families with special trauma histories. And then we have Sweetser, who is covering sort of our broader southern Maine area that has implemented a Children's Act team in our most southern county. And they also have been setting up community center hours for folks to walk in and have immediate access to a care coordinator or a peer, have the opportunity to utilize the internet and computers to apply for insurance as needed, or employment as needed, or education settings as needed. So we have seen a lot of innovation occurring across our 5 different CCBHC locations. And then the next slide is just really looking at the growth of enrollment from initial implementation, where in March of last year, we started with 3 providers. In July, we included KBH into our demonstration. And then in January, we incorporated Spurwink in the Cumberland County area. And as you can see, we have definitely grown the number of individuals that are able to access the comprehensive array of CCBHC services.
Thanks so much, Sybil, for that. Next, we will hear a bit from the Rhode Island model. Susan?
Hi, everyone. My name is Susan Stevenson, and I direct CCBHC services at Gateway Healthcare. So we are a clinic, although actually Gateway has 3 clinics of the 8 in Rhode Island. I'm going to give you a little bit of the history of Rhode Island's CCBHC model. In the fall of 2022, we launched the initiative, although Rhode Island actually began exploring this model back at the very beginning. I have notes from 2016 of when we were looking at what it would take for the state to become, get a planning grant and become a demonstration state eventually. Ultimately, many of the organizations in Rhode Island applied for and received individual SAMHSA grants to launch their own CCBHC. But in the fall then of 2022, the state launched the initiative to become a demonstration site through SAMHSA and to have the development of the CCBHC framework statewide. We began the planning and implementation of the program. It was a collaboration between the state departments under the Rhode Island Executive Office of Health and Human Services, which also administrates the administration for our EOHHS and the Medicaid plan. So it also included the Rhode Island Department of Behavioral Health, Developmental Disabilities and Hospitals, and the Rhode Island Department of Children, Youth, and Families. The state ultimately, after a lot of planning and process for applying to become individual clinics, the state awarded certification to 8 organizations, 7 of whom were CMHCs that had been part of the state structure prior to the CCBHC. And with that, it was accompanied by infrastructure development grants that were appropriated by the state legislature to help each of the organizations begin to expand their staffing, enhance their information system technology, and also to begin to build the community partnerships, which would prepare the state for applying to become a demonstration state. So we did apply, and we were selected as one of the 10 states to participate in the federal demonstration program using the prospective payment system, which you heard a little bit about from Lisa in the beginning. Our system is the payment system 2 of the model. There are 4, and I'll talk just a little bit more about that. And I know I'll probably be mentioning that as we go on. So the 8 participating organizations went live altogether in October of 2024. So we've now completed almost a year and 2/3. We count the months. So we have been very collaborative across our organizations in the models that we are following and the services that we're providing, and certainly work very closely with each other. As you know, Rhode Island is a small state, and so to have 8 CCBHCs within our borders, it means that we all work closely together. So Ash, you can go forward. So the state had determined that our priority populations here was the SMI, severe mental illness population, and then the SED population for children, and also our SUD population, substance use disorders. So those were our 3 categories that we determined would be special populations under the PPS 2. So we had identified separate rate structures for those 3 populations. In addition, our goals with the CCBHCs was to really expand services to reach underserved and under-resourced groups who experience barriers. And the identified populations included our older adults, our transition age youth, justice-involved youth and adults, and also those who experience housing difficulties. So during the first year, from the beginning of October 2024 through the September end of the first year, we had served about 16,700 Medicaid members across the state, which was a 7% increase during that first year from the beginning to the end. And about 77% of those were adults and 6% were youth. So we did see the increase in all of our populations. We are working hard, though, to increase the services that we're able to extend to children and youth. That is a priority population, certainly for Gateway. I think that we saw some of the greatest development and growth in our crisis services, which include both in-home and in-house, meaning we provide crisis services to walk-ins and people who call for immediate appointments, and also through our mobile crisis services, which are provided in the community. And through those, the state was able to successfully divert an average of about 80% of our clients from hospitalization or arrest and stabilize them in the community. And the other significant piece of data from this is that our average time for response to a mobile call was a face-to-face evaluation within an hour. So right now, I also wanted to emphasize that I'm reporting on our statewide data. So this is not just what Gateway has accomplished within our own clinics, but rather this is our progress across the state. Our another piece of data that is very important to us, and I know Lisa talked about in the beginning, was the area of time to service. That the goal of CCBHCs is that a person would begin treatment within 10 days from the time that they first made their call. That has proven to be a little bit more challenging for Gateway. We are getting people in for their initial evaluation, or not Gateway, this is again statewide, but we're getting people in for their initial evaluation within about 6 days. But the average time to start treatment is about 15 days. And that varies over the type of treatment that is being provided, but the average has been that. So that's a goal for Rhode Island as we move forward, is to begin to see that decrease.
Susan, I'm sorry to interrupt. Just a quick little time check. There is so much rich information here, which I want us to be able to cover. Do you mind if we cover some of these details during the panel discussion portion?
Yes. Yes.
Wonderful. But this is so great. And as mentioned, folks will have these slides in hand to come back to. Before I move us along to Massachusetts, Susan, is there anything here that you would love to just really call out and highlight at this point?
No, you can go ahead. This is just a little bit of Gateway's data showing the amount of individuals we cover and the kind of geographical area that we serve.
Really impressive that Gateway's 3 clinics cover just under 40%, right? This is fantastic for us to come back to, and please keep these thoughts in mind as we go into the panel session. So with this said, I am going to hand it off to the Massachusetts team to speak a little bit about their flavor of CCBHCs.
Great, thanks so much. And my name is Margaret Eichner. I'm Deputy Director on our BH policy team. I also have Lee Robinson, Associate Chief for BH with Mass Health, which is the Medicaid agency. And you can go to the next slide. So for this context, want to frame that Massachusetts has taken a little bit of a different flavor. We did participate toward the start of the CCBHC model in a planning grant for the state, but ultimately, before Lee or my time, did not move forward with the statewide demonstration. However, in response to the emergency room boarding crisis, we did want to move forward with a model that would better support access for our state. So the model that has been developed was set up in 2023. And so we have had a statewide network of providers for the past 3 years. They are providing a model of care that is in a lot of ways aligned with the CCBHC model, but with a few specific tweaks for the Massachusetts context. So the goal really for our CBHCs is, again, to increase urgent access and creating a front door to care for folks who may not have engaged with care recently or before, but also integrating that in a outpatient setting with wraparound multidisciplinary teams who can support them once they're in the door, and also integrating that with a strong crisis system, both for crisis intervention and stabilization. So just one more piece on that slide, sorry. Just highlighting here that we do have 3 core services that every CBHC offers, and it is offered both for adults and youth. The core services include integrated mental health and substance use, as well as peers and groups and other core pieces, and highlighting that mobile crisis teams provide the immediate crisis triage and evaluation. And then we do have a 24/7 bedded level of care integrated in the CBHC model, which is community crisis stabilization, which is appropriate for folks who do need that 24/7 care, but may not meet the criteria for inpatient or may be better suited in a more community-based setting. More to talk about, but I know we're a little short on time, so I'm going to highlight a couple of the statistics. There are 31 sites across the state which provide statewide coverage, and that does include Cape Cod and the islands, which we are happy to include there. We do have authority for this under Medicaid through our state plan, as well as 1115 waiver for our community crisis stabilization beds. And we do have a specific state methodology to pay. We use a bundled rate that supports multidisciplinary care for the outpatient clinic. And we also have per diem rates for mobile crisis and our CCS. Since 2023, we've served over 48,000 youth, and a lot of those youth have been in the outpatient setting, but in particular, I think we've seen a uptake of the crisis services with 21,000 youth served by our mobile crisis teams, as well as almost 2,000 served in that 24-hour diversionary level of care. I will highlight one core piece of the model is also integrating these services to be able to do police drop-off at these sites, as well as being able to do direct admissions for people in crisis if they need it to inpatient psychiatry. And that includes medical screening on site to be able to do that. We've had over 700 direct admissions from the CBHC setting to an inpatient facility, meaning that those folks have been able to completely avoid the emergency department and any care there, and being able to access inpatient psych facilities directly. Again, I think strengths of the model are also integration of care across teams, inclusion of peers and family partner supports, as well as working across many levels or many parts of the system to coordinate that care. So care coordination is also a key feature here. Also want to highlight that we do have the CCBHC model as an insurance blind option for all comers, and that's partly funded by state trust fund that allows clinics to be insurance blind and have an option to bill for all services. Also just highlighting that evidence-based practices are a key requirement for our CBHCs, including some modalities for youth, and that we have created a free training opportunity for all staff at CBHCs and beyond through partnership with our UMass Medical School, where the BH Training Clearinghouse provides free training and continuing education credits for CBHC staff, including on evidence-based treatments. So I know a little short on time, so I won't keep going, more to say, but happy to talk about any questions in the panel.
Thank you, Margaret. And I think that in each of the state's presentations, they've started sprinkling in what we're going to cover in with the panel. So let's kick off formally. We have a series of questions. I think what we'll ask for is kind of lightning round responses, and we'll go around the horn. Whoever is most comfortable can go ahead and mute yourself or raise your hand and provide a response. But the first question is, specifically, even building off of what you've shared already, is how has your state leveraged CCBHCs to enhance children's services? Are there any specific EBPs, DCO partnerships, and/or strategic care coordination partnerships that you'd like to highlight and encourage others to consider?
I guess I'll start us off. So in Rhode Island, I know that we have focused a lot on increasing the evidence-based practices that are being used in the CCBHCs. I know many of us have implemented TFCBT, trauma-informed CBT, as an important component in providing services to the children and youth that we see. Also, some of our CCBHCs have focused in on early childhood interventions, providing intensive home-based and partial hospital levels of care. And another area of focus has been on parenting and parent support. Obviously, when we treat children, we are working with the entire family. So that has been, I would say, the general focus in children's services, but also we do a lot of partnering with schools. And we have it, I know all the CCBHCs are embedding clinicians in the schools to provide direct services and consultation. So I'll let someone else jump in.
From a Maine perspective, I think that we have done a really great job of selecting a broad array of evidence-based practices that could either be required and or allowable, that a clinic could choose to incorporate within their cost report. One of the other really neat innovations that we have seen is our Kennebec Behavioral Health Clinic has incorporated some community health workers in a school system so that they can provide the telehealth component, in connection with a clinician, but with a CHW on site at a school, helping to make that connection and ensure that folks can access their virtual appointments. So I think for a rural state like Maine, that has had some significant value add as well.
I just echo a couple of points on Massachusetts front. I think the evidence-based practices, I think trauma-focused CBT is requirement, and some other pieces. Also just that we have offered group therapy services, which is a increasing part of the model that might include parents and caregivers. And also that they are required to coordinate care and transitions of care with schools, and also with our set of services that are focused on high need youth, our Children's Behavioral Health Initiative, and really collaborating across the system there.
Thank you so much. And I know, looking broader across other states, there's been areas of focus, care coordination with those in foster care, understanding the complexities of the situation and providing additional supports for the children and the foster parents so that they can thrive. So many different areas that we can explore further. The question number 2 then is, what are some areas for each of you in your states that you think should be further explored? In other words, how do you think the CCBHC model could be further optimized? What is the next frontier for your state? Because this is about continuous improvement and continued expansion based on experience and building over time.
From a Maine perspective, I can say, part of the scope of services that you shared is really that screening and diagnostic evaluation component. We have seen some of our landscape change when it comes to specific specialty diagnostic assessments being available to families, and that component is really, really vital to getting you the correct service. And I think further defining some of the required assessments that could be part of the model, and then the appropriate staff to do those or perform those assessments, specifically for youth developmental type screening and assessment, would be a value add for our CCBHC model in Maine.
For Massachusetts, I think we are thinking just still a lot about behavior change and culture change. CBHCs and all of the offerings that they provide are still new to folks. And while some people may instinctively know what urgent care is for medical side, they don't necessarily know or have an instinctive way to understand that for both crisis and urgent access. And that's really across, all the residents of Massachusetts, but also increasing awareness in the provider community and being able to coordinate there as well. And just wanting to increase collaboration, I think, across systems, including with schools and other child-focused settings.
So in Rhode Island, I know that we are all focused a lot on workforce development and building a pipeline into the behavioral health services, particularly for children, possibly through career ladders and internships and so on. So that is an area that I know we struggle, and that's probably the largest component that limits our growth in children's services. So I know that there is an opportunity there to really explore ways that we can create some specialization too in children's behavioral health for either diagnosis or family therapy, social emotional development, and so on.
And I'll just lean in there, Susan, to say that workforce challenges are not unique to the state, if that makes you feel any better. Working across states, it seems to be a common area of consternation, and it's just where we are. And so it's been interesting to see different opportunities evolve from that, with everyone acknowledging that it is a constraint across the entire healthcare landscape. And conversations about, one, should we be thinking about how else we can be leveraging paraprofessionals to lean in? How do we optimize who we currently have in the workforce and retain them? And then three, strategies for upskilling to bring people up where needed through licensing. So lots to explore in that space. I know Kaiser Permanente has had some accelerator incubator programs. So it's something for everyone to keep an eye on. All right, the third question, which kind of leans into a question I saw added in the chat, is it's a two-parter. One, how is the program currently funded in your state? And then the second part is, let's be frank, what are some sustainability challenges that you've been encountering? And what are some strategies or braided funding approaches that you would consider, exploring yourself or recommending to other states?
So within Maine, we are a demonstration clinic, which we also have to seek out legislative funding for the state share, but we do get enhanced match. Maine is a PPS2 state, which means providers are given a monthly prospective payment if they provided one of the services that triggers a payment. And then Lisa, I forgot the second part of that question, but I think a pain point on sustainability will be a lot of folks that started out in the demonstration had a longer runway of participation. So they were able to participate for 8 years in the demo. Currently, Maine, and then I think the newer states are really looking at a 4-year participation within that demo, which does give us that enhanced match. And then when you're looking at transitioning over to a state plan amendment for future sustainability, you're looking at maybe or potentially costlier model on the state side. So that would be a sustainability pain point that Maine will be seeing soon.
For Massachusetts, we do have a little bit of a different funding than the CCBHC model, but we do have daily rates for our outpatient front, which covers all services provided on that day. And then for mobile crisis, we also have per diems for any service provided and whatever length of time is spent on care. And for our community crisis stabilization, it's also per diem for each day they're in the service. I think the services that we have are Medicaid reimbursable, but we also have worked with our state regulated health plan who are mandated to cover CBHC services. So that has helped support, again, all comer access. And as I mentioned before, we have funded on the state part for anyone who may need services who is either uninsured, has Medicare or a federally regulated insurance plan to support that. One other thing I would highlight on the Massachusetts model is all clinics receive the same rates that we set. but we do pay higher for child rates across the board for all services, and want to keep prioritizing that, knowing that child access is very much needed at this point.
So Rhode Island has the PPS2 model similar to Maine. Each clinic, though, has its own rates that have been set based on its cost reporting process. So those are individualized according to the population acuity levels that are served. The PPS2 is included both with direct Medicaid and with our MCOs, our managed care organizations. The thing that I would highlight also in Rhode Island's children's services is that we have a lot of other children's services that are not part of the CCBHC, and that's one of the areas that I think we need to begin to look closely at in how they overlap or integrate with each other, because there clearly are many providers out there providing valuable services. We also have commercial insurance that the CCBHCs are accessing for the clients that come in who are not Medicaid recipients, and also our contracts with our state agencies. So all of those work together to serve the children across the state. And I know that we want to continue looking at ways that those are going to connect and coordinate with each other.
Great. I'm going to go to the last question just because I know folks are eager to ask what's on their mind, and there's some good stuff here I want to get to. So the last question I'll pose for the formal panel is, the Rural Health Transformation Program, RHTP, is a new significant source of federal funding for all states. How is your state strategically leveraging this funding to enhance or build upon the CCBHC model? Or is this still a space that you're exploring and trying to figure out? Curious to hear what folks currently have planned.
From a Maine perspective, I think one of the most innovative or exciting initiatives that we did incorporate within our RHTP application was the ability for CCBHCs to establish agreements with primary care partners to provide on-site primary care, and allow for, point of care testing for certain infectious or chronic diseases as well, in partnership with their primary care provider. But we are still navigating through that process. We also do have some funding for EHR upgrades for CCBHCs as needed, beyond what they incorporated into their cost report. And then we're also looking at alternative payment model transformation funds, which is really trying to support the provision of care beyond just the Medicaid population, but within the full CCBHC panel.
So, sorry, go ahead.
Sorry, can folks hear me? Great. So I think in Massachusetts, one of the things that we're excited about with the Rural Health Transformation Program is this topic of kind of graded funding, thinking outside of the Mass Health space. One of the things that we've noticed is that on the youth side, particularly in the bedded programming space, there are services that Mass Health covers, there are services that our sister agencies cover. And because of the seasonal nature of youth needs, it's oftentimes hard to make sure that all of our resources are optimized and maximized, in the sense that there's oftentimes of the year when this agency has open beds and this agency needs a lot more beds than they currently have. And so one of the things that we're going to be working on is to build out full visibility into those resources across the state, so that we could then be much better prepared to optimize those resources and grade funding and capitalize on maximizing federal revenue. And I think that, one of the main drivers for that is the fact that, these programs that we're trying to optimize, so few of them are actually in rural areas. So for us, it's the western part of the state and the Cape and the Islands. And so those populations are really dependent on a statewide network that we just don't have full visibility and that we don't actually treat as a statewide network at this time. So that's one of the things that we're really excited about.
In Rhode Island, we have about 18 communities that are going to be designated under the Rural Health Transformation Program. And many organizations within those communities are collaborating to look at ways to better take the services to the various populations within their area, so that it's focusing on outreach services, also embedding behavioral health services in organizations that are already places where people in those areas go to, schools, churches, social service organizations, and senior centers, so on. Also, funding to cover the outreach and engagement that is so essential to getting services into the rural areas. Also, some of the groups are looking at embedding clinics in schools where families can better access services for the whole family, not just for the children in the school, and certainly integrating that care between both primary and behavioral health. And then another focus is on workforce development, which we've already talked about.
That's excellent. Ash, I'm going to look to you because we have a minute left and there is not nearly enough time to go through all the thoughtful questions that have been submitted to us. How would you like to proceed?
Maybe just take one question. That's about it from the audience.
Great. Well, here's one, because I think that we've maybe answered some of these in our conversation lately. But I think the one I want to point out is, what have you learned that you wish you had known going into this process?
One word or so.
That culture change takes time, even at the clinic level, at the state level. I think, shifting your thinking beyond the fee-for-service landscape, it does take some time and some coaching and some partnership.
I would say that infrastructure development is essential. The systems that you need in place for managing data and billing systems, it's intricate and takes time and flexibility.
I think the one thing that we would say in Massachusetts, to kind of follow on with what Sybil said, that culture change takes time. I think connected to that is expectation management. That like once you stand these up, everything isn't solved. Don't print out the mission accomplished banners just yet. And so to set reasonable expectations for the coming years about what is possible.
Thank you so much. That was truly level setting, the last point. It takes time for this work to truly see its effect. On that note, thank you so much for joining in. It was such a wonderful discussion. For a few other questions that we couldn't answer, maybe we'll try a way to get to them. But thank you, each panel member, and thank you, Lisa, to moderate this panel so thoughtfully. Just a quick note, we're about time, but we have an upcoming webinar coming up next week, which is focused on ACEs. So looking into it more from a preventive policy and a regional lens. So we'll have about 4 states participating in that conversation. So please do join in if you're available. And speaking of workforce that we highlighted quite a bit today, we are having a conference in fall this year, which will heavily focus on workforce development changes. We'll be inviting workforce-centered thought leaders from across the New England region to share their ideas and perspectives on what they're seeing. And if you'd like to stay connected, please sign up to our mail list. You'll receive our blogs, webinars, and updates about events. You can also follow us on LinkedIn. And if you have any questions or concerns, please reach out to us. There'll be a survey which will follow up from this webinar, and it would be great if you could take a minute to fill that out. On that note, I'm thanking all the panelists again for joining us for this call, and we'll stay connected. Thank you so much.